Thank you for the opportunity to share my thoughts. I've been working on this for some years, and I think it's a very relevant topics. Can I have my slides, please? This is not my slides. No. Yes. Okay, I see it here. Yeah, I see it. Thank you. So small choroidal melanoma, I'm Arun Singh from Cleveland Clinic. So we talk about many things in uveal melanoma, and what really matters is the survival, right? Let me go back up into survival. That's the real thing, but if you look at the survival over time, you realize how small choroidal melanoma may be very significant. And this is not published yet, it's coming out very soon. This is a relative survival from what, how many, 40 years, maybe more? Talking about the relative survival with uveal melanoma in the United States, and has not changed. And we know why, very likely due to earlier metastasis. And if you really want to change this curve, you need to do early interventions, and that could be, we say, systemic approach for adjuvant therapy, that will be, and for tumors, we say it will be small choroidal melanoma. Because we know from COMS study that small choroidal melanoma have very low mortality, 1% at 5 years. So if you could theoretically treat everybody with small melanoma, you would improve their survival. So that's the significance of small choroidal melanoma. But the problem is with the definition. This is the definition or classification used by COMS. 1 to 2.5 millimeter in height, 5 to 16 millimeter in base. And they call these tumors just by size alone small choroidal melanomas. And in this component of COMS, this was not a randomized study, it was a non-interventional observation study. These patients were observed without treatment, and once the tumor grew, they were treated. About 140 some cases, and you realize over time, only a minority, 33%, actually grew. So here we have melanomas, which are true melanomas, only 33% of so-called small choroidal melanomas, because the other 2/3 actually never grew. So although we call these tumors small melanomas, in their clinical behavior or biological behavior, they are not really melanomas, not most of them, 2 to 1, mostly nevi. And therefore you have this terminology such as suspicious nevus, atypical nevus, large nevus, and you'll hear all these kind of words. And nobody really knows what they're referring to because you're not giving size with it. So this is the first dilemma, is the name itself. Something is wrong with the name. We can't call them small choroidal melanoma because they are not. So the better terminology may be IMTs, or indeterminate tumors, and you can read an editorial related to this. So let's start at the name. We say stop calling them small choroidal melanomas. But if you look at the published literature, everybody has tried to define it their own way. This is before COMS, some of the studies. Some by one dimension of basal diameters, some by areas, some by volume, and some by growth, the fourth dimension of time. And we say relevant nowadays, I guess, is the growth. Going forward, we say what's the risk of these nevus or these small tumors or indeterminate tumors becoming melanomas over time, and the numbers go from 0 to 40, depends upon the inclusion criteria. If you take smaller ones, none of them will become melanomas. And if you take a slightly bigger ones, some of them will be melanomas. So again, very useless to some extent, because the size criteria is all over the place, so really nothing. So although we think small choroidal melanoma is an important thing to diagnose, we really don't have any definition for it. And when it comes to diagnosis, we nowadays rely on clinical diagnosis, go by growth, but again growth, well, how much, which type of growth, volume growth, base growth, height growth, what's the rate? And we really don't have much pathology on small choroidal melanomas because they're not typically biopsied for diagnosis. And what's really missing is the link between the pathology and the growing small choroidal melanoma. And this is the missing part. And we tried to generate some data and that was also published. So by the way, there is nothing like a growing nevus from one visit to the other. That's actually malignant transformation of nevus to melanoma. If I can see so-called nevus grow from one visit, 6 months later bigger, that's not nevus that's growing unless it's a child. This is all malignant transformation. And all we're trying to do in clinic is trying to do this some kind of prediction as to this tumor that I have in front of me, is it nevus or melanoma? And if it's nevus, what's the chance it may become melanoma in the future? Getting into this prediction business without having any real definitions to start with. And we talked a little bit about this clinical path correlation. Most of the time when you document growth in small choroidal melanoma, it's in height. Not so much, in height, mostly in base. And the growth rate for small choroidal melanoma, which are biopsy proven, is roughly 1 to 2 millimeter per year, compared to nevus, which is 0.01 millimeter per year. So nevus growth is not observable over 1 year, whereas melanoma growth is. And I'll stop there, maybe have a few more seconds. We talk about drusen being a negative factor because it's a sign of chronicity, and orange pigmentation is a sign of acute change. So something acute, maybe malignant, something chronic, perhaps benign. And if you look back at the COMS data, because prospective data, you can only say 50% melanoma and 50% not melanoma. So when you have a patient in front of you, you try to figure out if it's nevus or melanoma, and all you can say is gamma relative scale. What's the chances that this tumor is melanoma? And the last thing that comes up, and that's not realized very easily, is that most of the time we do all the testing and make a diagnosis and then offer treatment. But what's happening in our literature is that if we decide to observe the tumor, we call it a nevus. And if we decide to treat it, we call it a melanoma. The diagnosis is not causing the treatment. Treatment is changing your diagnosis. Thank you.